Hello, everybody, and welcome to Zoom World. We're going to talk about cervical cancer. And what I wanted to do was to review statistics, think about it in the big picture, think about etiology, and then finish with talking about screening and management guidelines. My name's A.K. Goodman. I'm a gynecologic oncologist at Massachusetts General Hospital, and it's a privilege to participate in this learning experience. So I have no disclosures. Let's just start with statistics. Cervical cancer in the United States is not a very, very big cancer compared to the rest of the world. In the past year, we've had close to 14,000 cases of cervical cancer diagnosed. One thing I would say, because I've been watching the statistics every year, is each year we have a few extra hundred women diagnosed. And I'm not sure if that's just representative of a change in our population. But last year, 2019, it was 13,500. We're up a little bit from that. A few more deaths this year, 4,290. Clearly not compared to breast cancer and lung cancer and so forth. In the United States, in terms of the populations and subsets of our population, this is the most common cancer, the seventh most common cancer in people who identify as white, women who identify as white, and now same for Black and Latino women. This is interesting because back in 2019, this was the 11th most common cancer in women identified as white, and the 6th most common cancer in Black and Latino women. So if we sort of break down incidence per 100,000, you see it here, and you also see underneath that the numbers. This comes from the most recent CDC population statistics, and you see the death rates per 100,000 in the United States. So I'll just take a moment so you can look at the slide. When we look at the world, it's a different story. It's a very common cancer, especially in less developed countries. You see that worldwide, according to GloboCan, which is a global World Health Organization that keeps track of cancer statistics, we have about 500,000 cases. And you'll see that the majority of these cases and the majority of deaths occur in less developed regions. And when you actually look at the number of deaths, it's about at least 50% of all cases. And then when you break it down, these are a very important and problematic situation in Africa, in South Asia, and in areas that have low resources compared to the United States and to Europe. So it's clearly worldwide what we would consider the second leading cause of cancer death for women. So my first question to the audience is, what do they think are the vulnerable groups in our society in North America, just thinking about North America, for a missed diagnosis of cervical cancer? Who would you think are the most vulnerable in our society? Well, turns out the elderly, and we'll talk a little bit more about screening guidelines and where we can miss that group. Minorities for sure, lower socioeconomic status, and women who have challenges to healthcare insurance. And another group that's very underrepresented in terms of the literature, but is a very problematic group in terms of cervical cancer rates, is the prison population. If we look at just sort of focusing on age, if we look at the United States and look at cervical cancer by age, you'll see that the average peak age of cervical cancer diagnosis is 40s to 50s. That rate decreases with age, but it does not go to zero. And you'll still see this is rate per 100,000 women, age based. And you'll see that even up into women in their 80s, you have a rate of 10 to 15 per 100,000. What's very noteworthy is if you take a look at age-specific death rate, okay, again per 100,000, and you'll notice that it goes steadily up with age. And part of that can be explained with misses of cervical cancer as women get older, and also that women who present with cervical cancer diagnosed over 65 are usually at advanced stage compared to women who present in earlier age groups. And I bring that up because even though screening guidelines suggest that there is an age that we can stop screening for cervical cancer, we need to be very, very careful that we know who to screen and who it's safe to stop screening for. Finally, I want to point out that we are seeing a disparities in the incidence of cervical cancer per 100,000 based on states. And this map of the United States shows that regionally, there's a much higher rate of cervical cancer in the South and Midwest than in the North and East Coast and in the West Coast. And you'll see there's a sort of twice the number of cases in the southern states as listed here: Florida, Texas, Louisiana. It's unclear why. It might again be related to poverty, might again be related to access to healthcare, and it might also be related politically to the loss of a lot of free and low budget clinics, Planned Parenthood, for instance, in some of these southern states. But we're definitely seeing, because of that, increased rates of cervical cancers in these regions. All right. So if we think about cervical cancer and why, compared to the rest of the world in the United States and in Europe, there are much lower rates overall, it's because of screening. And the rationale for screening is that cervical cancer has a long pre-invasive phase. We have very low budget, effective, cheap screening tests. And theoretically, cervical cancer could be prevented by identifying pre-invasive lesions. When you look at this data and you look at who gets cervical cancer, about half the women who are diagnosed with cervical cancer in North America have never been screened, or it's been more than 5 years since their last screening. There has been, and this is pre-HPV data, a group where there are misses based on cytology screening alone, which is why we now include HPV testing as part of a screen. Probably about 20 years ago, 10 years ago even, it was standard to think about annual screening, very aggressive evaluation of even minor changes in pap smears. And this led to some overscreening and consequences of overscreening and overtreatment that has led to our more current recommendations for screening intervals of 3 to 5 years, which I will go over. The other thing is that for low-grade lesions, there is a probability of a spontaneous regression. Things that are called low-grade or mild dysplastic changes can regress on their own 80% of the time. And even moderate dysplastic changes can regress up to 60% of the time. So there's this interesting balance with wanting to not miss anything and the potential of overtreatment. So we balance this with our screening guidelines, which I will go over. So when we think about the etiology of cervical cancer, just about all of it is due to human papillomavirus. And this is a very, very common infection that can be an exposure for the majority of sexually active women. However, the majority of HPV infections will resolve with time. Only a minority of them will lead to pathology. There are high-risk subtypes that are the ones that are involved with cervical cancer, and listed here are the panel of high-risk subtypes, the most famous being HPV 16 and 18 that make up about 70% of all cervical cancers have this particular exposure. Low-risk subtypes like HPV 6, 11, and so forth are really related to non-malignant changes such as genital warts. So, as I said, HPV is a very common exposure, and high-risk HPV is the most common exposure. There is an incubation period after an exposure. This is transmitted sexually between 3 weeks and 8 months from exposure to potentially seeing a manifestation of HPV, either related to a change in a pap smear or in the setting of a low-risk HPV, a condyloma. There are a few non-sexual ways of transmission. Vertical mother-fetus is the one that's most famous, although also pretty rare. There can also be exposures for healthcare providers when working with lasers. So now we have very good laser masks to prevent that from getting exposure in the nose. The overall prevalence of high-risk HPV is 45 to 50% and a very high lifetime risk. And in this graph here, you will sort of see the prevalence over time. The highest period of time where you'll see HPV-related changes is in the 20s and 30s. Most of that will clear, and there will be an immune response to that. And then by the time you're in your 40s and 50s, the prevalence is much, much lower. So if we think about all the HPV-related disease in the United States in terms of a big pyramid, there's a tiny amount that leads to cervical cancer, as shown in this graph. The majority is cleared. However, one of the most important risk factors for the development of cervical cancer is the lack of clearing of HPV infection. Having persistent high-risk HPV, which is seeing HPV-related infection or being positive on an HPV test for more than 3 years, is a risk factor for the development of cervical cancer. I would say that always is a risk factor for cervical cancer is the lack of screening. But what you see here in this graph is increasing prevalence of potential disease as you have persistence related to age. So if we take a look at, well, if someone has a normal pap smear, do they have some HPV present? The answer is yes. And you'll see in this particular study, looked at women at various age groups, as shown here, from teenhood to women in their 80s, who were tested both by cytology and by HPV. And you will see that there's this positivity rate in the setting of normal cytology. This fact, again, also is important in thinking about the misses of cytology by itself, is that potentially some women with normal pap smears, about depending on the age group, 4 to 8% can have high-risk HPV that potentially puts them at risk for neoplasia. The old risk factors are still important to think about because I think about them in terms of two factors. One I would call the social ecology of cervical cancer, which is poverty, potentially exposure to risk factors by multiple sexual partners, use of tobacco, which can be a cofactor. That's one group. And then the other is the issue of potential comorbidities such as immunosuppression that can also contribute to the lack of clearance of a high-risk HPV. We think about histologically what happens. You get HPV infection, it causes a change, and you'll see slowly over a period of years a change in the stratified squamous epithelium in the genital tract, most significantly in the area of the cervix, but it can also impact the vagina, the vulva, and the anal area with the same process where you start to get some dysplastic change in the basal cell lining. And then over time, this progresses from a mild to moderate to severe dysplastic change. Carcinoma in situ is when there's a dysplastic change that involves the full thickness of the squamous lining. And a change to cancer occurs when there's a penetration of the basement membrane and invasion. So that's our sort of standard diagram. We talked about the incubation period of HPV high risk, and we talked about persistence. Again, just to point out that the majority is cleared within 3 years, and most of it is cleared within 1 to 2 years. So if you have an HPV high risk and you follow that patient, you most of the time will see that HPV clears. Okay. All right, so how do we prevent cervical cancer? So there's two ways. One is vaccination, and the other is screening. So for the remainder of this talk, I'm mostly going to talk about screening, but just to talk a little bit about vaccination, it's now quite clear from over 20 years of studies that vaccination is safe, that there are no significant adverse side effects to vaccinations, and they are recommended routinely for boys and girls and adults. And the standard current recommendation is routine vaccination between the ages of 9 and 26. For those who did not get vaccinated as teenagers, catch-up HPV vaccination is recommended. And most recently, the FDA has approved vaccination for catch-up up to age 45. The sort of wording of the recommendation is that for adults greater than 26 to age 45, there should be shared clinical decision-making about benefits of catch-up vaccinations. There is no current recommendation for vaccinations after the age of 45. The vaccine that's used is a 9-valent vaccine in the United States, so 9 different HPV subtypes, and the doses are before the age of 15, 2 doses, first dose times 0, second dose between 6 and 12 months. After age 15, 3 doses are recommendation, and for immunocompromised patients, 3 doses are recommended. Okay. I want to be kind of old-fashioned here and talk about the importance of the physical exam. In terms of cervical cancer screening, people who unfortunately come in with a cervical cancer this can be diagnosed by visual inspection, and we'll talk about that at the end a little bit. We hope to find things where they're pre-invasive, where you can't see them, where it's only based on HPV and pap smear testing, but you will most likely in your practice come upon women who have already a cervical cancer because they haven't been screened, because they fall into some risk category based on not having insurance or not having capacity to get screening. Visual inspection with acetic acid is a tool that's used in low resource environments to evaluate the cervix. What this does is it dehydrates the stratified squamous epithelial mucous membrane, and areas that are more nuclear dense will look white. You can actually see that with your eyes. And this is a common tool for screening in low resource environments around the world as a first triage when you don't have a lot of resources for laboratory testing. Pap smear and HPV testing is the standard and is done whenever there are the resources to do it. And the final diagnosis of a cervical cancer is made based on a biopsy. So, like I said, I cannot stress the importance of a pelvic exam, both a visual inspection and then a palpation. And so just to walk through that, a bimanual, which is shown here, allows you to palpate the size of the uterus between your examining hand in the vagina and your palpating hand on the abdominal wall. This can be incredibly challenging if your patient is overweight, or if they have a lot of tension to their abdominal muscles and don't allow you to examine them. And therefore, it's extremely important in evaluating cervical disease to do a rectovaginal exam. Basically, with a rectovaginal exam, you do not need to palpate the abdominal wall, and additionally, you'll be able to feel the area of the cervix and the ligaments between the uterus and cervix and the pelvic sidewall. In the setting of cervical cancers, they can be involved, and you will feel on examination a hardness there. So that is something to consider in your examination of your patients. Visualizing the areas is extremely important, and HPV-related disease can be multifocal. It can involve the vulva, the perianal area, and therefore these areas need to be evaluated. So I think that evaluating visually the perianal area should be part of a pelvic exam. You can see pigmented change with a sharp boundary that suggests pre-invasive disease. Examining the cervix and the wall of the vagina is very important. And as I said before, palpating with a rectovaginal examination. In terms of pap smear screening, you usually have two pieces of equipment. You have a spatula of some sort, or a cervix brush, and a cyto brush. And the spatula or cervix brush gives you a good sampling of the cervix and the vagina, and the cyto brush is where you get your endocervix. And it's very important to have both, that then are placed nowadays mostly in liquid-based medium, and the tips usually are broken off and just left in there for processing. Okay, I would say that probably universally in high resource environments, thin layer cytology is now performed, although in lower resource environments, the more conventional slide-based pap smear, you put it on the slide and you then put a fixative on top, is still performed. In terms of HPV testing, in the setting of using a liquid-based cytology system, you can either request HPV testing, or you can set up your request to do what's called, to do testing in the setting of an abnormality such as atypical cells. That's called reflex testing. Okay, so basically the HPV test comes from the liquid-based um, screening, so it's just one material that's sent off, and testing should really only be confined to high-risk subtypes. There's really no need to test for low subtypes. There's no clinical relevance to that. Ultimately, in the setting where, based on the Pap smear report or based on your high-risk HPV report, you will refer to colposcopy. Colposcopy is done, cervical biopsy is done, and that's where your diagnosis of a pre-invasive lesion or a cancer is ultimately made. So let's talk about screening guidelines. There's sort of screening guidelines, which I think everybody pretty much knows at this point. And then there's the hard part, which is what to do with those reports. Okay, so we'll sort of finish. This is our last section. We're going to finish up with this. Basically, when we think about guidelines, they really pertain to women who are at average risk for cervical cancer. Anyone who's at high risk for cervical cancer, these guidelines don't pertain. So someone who has a previous history of cervical cancer, say treated with radiation or treated with a hysterectomy, for that group of women, there's a set of follow-up after treatment guidelines that ultimately is at least annual evaluation with Pap smear cytology. The cohort of women who are exposed to diethylstilbestrol, who have an increased risk of pre-invasive and potentially invasive disease in the vagina and even on the cervix, they were born between the 1950s and 1970s, so they are now in their menopausal years, and their guidelines for screening them have been annual. Any patients who are immunocompromised should be at least annually screened. So regular screening guidelines don't apply to this group. Recommendation is to start screening at age 21, and that the screening guidelines then are age dependent. Okay, the annual Pap smears, as I mentioned earlier, are no longer recommended in average risk women because it leads to overscreening and potentially treatment of low risk abnormalities. The other important thing is screening guidelines to date have not changed based on vaccine status. So continue to screen regardless of vaccine status. But it also, in your under 26-year-old patients and under 45-year-old patients, is an opportunity to discuss the HPV vaccine. For women aged 21 to 29, the recommendation is for every 3-year Pap smear screening. There is not HPV testing, especially for those under 25, but reflex HPV testing is recommended to evaluate certain Pap smear findings, such as atypical squamous cells of uncertain significance. For women over 30 to age 65, there are 2 options. You can do Pap smear plus HPV testing every 5 years, or you could do Pap smear testing by itself with reflex HPV testing every 3 years. There has been a discussion of offering HPV testing alone for women over 25 every 3 years. I don't know that that's really taken hold yet in the United States, but it's out there. So in terms of women greater than 65, why is it that we continue to have a problem with this group of women having cervical cancer and having the highest death rate per 100,000? It may be in part due to a lack of appropriate decision-making about when to stop screening. It's very, very important is that there's no further pap smear screening only in the setting of a woman who's had 3 or greater consecutive normal pap smear tests, or 2 or greater consecutive negative HPV and pap smear tests. And it's really important to be sure you have those reports, especially if this is a new patient who's come to you and you do not have that information. My recommendation is, if you don't know, it's better to screen them and be sure. There is also the tendency on the part of women to be maybe not come in for screening after their children. As a gynecologic oncologist, I would say a lot of the women I see who come in with cervical cancer have not been screened by pap smears for over 10 years. For them, they got busy with their children, with their jobs, they didn't come in for screening. So something that's very, very important to be sure. Women who've had hysterectomies for benign disease are another group when you can stop pap smear screening, again in the situation where they have had normal pap smears before their hysterectomy. This is a slide that I took from Up to Date, and I only put it here to encourage you to take a look at that chapter on pap smear screening and Up to Date. It basically gives you the guidelines as a nice summary chart and shows you who they've come from, the different various groups, American College of Obstetrics Gynecology, the American Society of Colposcopists and Cytopathologists, and so forth. So that's just for you to remember that there's some good guidelines out there. So here's my question to you. What situations would you not follow screening guidelines for cervical cancer? All right. It's really important that guidelines should never replace clinical judgment. So even in the setting when someone has normal pap smears and has no previous history that makes you worry about them being high risk, if they present with irregular bleeding, a persistent abnormal vaginal discharge that's not related to vaginitis or Gardnerella or something like that, if they have postcoital bleeding, you should be very thoughtful and examine them. Use, when you're in doubt, if you don't know, if they come in with a history like this, do a physical exam, take a look. What I have here are several slides of pictures of abnormal cervices ranging from, on the left is a pre-invasive lesion, and the next one over is carcinoma in situ. The next one over is a benign polyp that's sticking out of a normal-looking cervix. See how normal that cervix looks. And the final one is an invasive cervical cancer. So you can, by looking, see that something doesn't look right and that this person needs to be referred. And you can do a pap smear, you could do HPV testing in that setting, and that will give you additional information. All right, I'm going to finish up briefly with management guidelines. And what I would say is that they have changed. There has been new guidelines that have come out by the American Society of Colposcopists and Cytopathologists, the ASCCP. And there is an app that is amazing. So this is my commercial for you to recommend downloading this app. And here's a picture of it on the side. And basically, these are evidence-based management guidelines. They're pretty easy to follow and they're uncomplicated. And the guidelines are based on age, risk factors, HPV status, and what the pap smear shows. And based on that, certain risks are assigned. Okay, so here's the download the app. Okay, and a certain risk level of the development of cancer is assigned, and based on that, a recommendation to go to colposcopy versus to repeat pap smear and so forth is made. Okay, so these guidelines, as I said, are age-based, they're risk-based, and they take into account the past history and the current results. And what you see in this figure is the various risk categories that are derived from large population studies of risk based on, as I said, risk, age, HPV status, and so forth. And the risk is divided into less than a point of a percent, up to greater than 50% risk factor for the development of a neoplastic lesion. All right, and so these are the different categories that you see that are divided here, from green, which is see in 5 years, to red, which is needs immediate evaluation. Okay, so that I'm going to go through one example for you, just to walk you through this app and the management guideline. You have a patient who is 45, and you did a pap smear on them. You didn't do HPV testing, and their pap smear came back atypical squamous cells, cannot rule out high grade, the ASC-H category. So when you go to your app on your phone, it will say, your age range is between 30 and 65. You're going to click on that. Then you're going to click on, this was your pap smear diagnosis. Then you're going to click on, nope, you didn't get an HPV. Then this particular patient in front of you doesn't have any previous screening results, so you click on that. And then you click on next, and it says this patient needs to go for colposcopy. So it will give you that follow-up. So here we are just looking at it in the more conventional triage. Basically, management of atypical squamous cells cannot exclude high grade. You go to colposcopy, and then this is regardless of HPV status. You get biopsies, and then of course, if you have a high grade based on your biopsies, that will go and that patient will be treated. If there's negative biopsies, they'll go back to pap smear screening and so forth. So you can easily, in the office or when you're reviewing your results and about to call or send a letter to your patient, follow up with these PAPs. And I would say I chose the Ask Age category for our example because I think that's a place where it's very, very easy to lose that pap smear report. It's a difficult interpretation. A lot of times, atypical squamous cells are misinterpreted as being benign, and that patient gets lost until potentially they come in later with a bigger problem. So I think that if we should just finish up with just a quick, what happens if people have pre-invasive disease? For sure, the majority of interventions require some sort of excisional or destructive procedure to remove what is seen. The situation of observation would occur in a very young patient with a tiny lesion that you think might regress on its own. Remember, I said that for low-grade lesions, there's an 80% regression rate, and for even moderate dysplastic changes, there's up to 60% regression rate. And if you're taking care of a young woman where you want to preserve as much cervix as possible, you could potentially observe that. However, if it does not go away, then she needs an excisional procedure such as a LEAP, which stands for Loop Electrosurgical Excision Procedure, a cone biopsy, freezing the cervix, or an ablation. Hysterectomy is really reserved usually for people with recurrent abnormalities, multiple previous treatments, and someone who has completed their children and no longer needs, is not interested in fertility. So in terms of hysterectomy, it can be done just straight through the vagina, it can be done laparoscopically, or it can be done with an incision abdominally. And the other thing that you can remind your patients if they're considering hysterectomy is this does not mean removing the ovaries, or, because This is really more about just removing the uterus in that setting. And that's really the end of my talk. Thank you so much for the privilege and opportunity to talk with y'all, and best wishes. And here's some references. Thank you so much.